Welcome, everybody. Thank you for joining us on a Wednesday. Uh, Tough time for all of us, I know, because we're probably all in the middle of practice. As I was telling Jerry, my heart rate, my blood pressure is probably going through the roof as I'm continually looking at my watch for my last patient to make sure that I was done in time to pop on. So I am here, and we're going to talk treatment planning, and we're going to talk about restoration versus removal, right? Something that comes across all of our clinics every day. You see a tooth and you're like, oh, I don't know, maybe I should just take it out and do an implant. And I feel that there are probably too many teeth being removed for implant placement because it's convenient and it's easy and it's got actually good predictability if you look at integration rates. The challenge with implants, though, is it's not as easy as a tooth. You don't just make an impression and then send it to your technician. You have to do a lot of work on the back end. You, as the restorative dentist, need to manage emergence profiles and soft tissue sculpting and choosing materials and cleaning cement and all of the things that go with it. Implant dentistry is quite challenging. And if you look at integration rates, as I said, they're quite high. The challenge we have with implants is making them look like they're not implants. And I'm betting that you know exactly what I'm talking about. You can look at a patient and see an implant across the room because you're looking at the soft tissue profile, right? Papilla levels, gingival margin levels, facial concavities. So if you look in the literature about how well we actually do implants aesthetically, there's ways that we can score our implants. We can score the soft tissue, which is our pink aesthetic score. We can score the crown itself, white aesthetic scores. And essentially what you're doing is you're using 5 variables you're looking at and you're scoring at 0, 1, or 2, right? So we can look at our implants now and say, okay, how well do we actually replace teeth with implants? And so I'm going to show you 2 papers. First one is from Belzer, 45 patients, 2 to 4 year follow-up, grading with pink and white aesthetic scores. Okay, so a perfect implant, pink and white scores would be 10 and 10 would be 20. Now, if you look at their study, their average was 14, their range was 11 to 18. That's amazing to me. Those numbers are outstanding, but also Belzer, that name is synonymous with excellence in dentistry. They never had a perfect implant. They don't have a 20. That's good. I don't have that case either. But I don't think 14 is normal. I think that's exceptional. This is another paper that looked at the same thing. Their average was 11. That means that they have cases that were single digits out of 20. I think that's more clinically real because implants are challenging. So can we do them well? Yes, but there's multiple steps that need to be taken and it takes a ton of time. This looks like a slam dunk, unrestorable left central, looks like an easy one, but there's a supernumerary tooth. And so in our treatment, this typically would be an immediate implant, immediate temporary, but we're going to have to take the tooth out, take the supernumerary tooth out and augment things. So I make a little bonded ponic to help hold the soft tissue aesthetics. And we cycle through extraction and grafting, come back later, do our implant placement. And all the while that pontic has been maintaining the architecture of the soft tissue so that when we're done, we end up with a pretty decent looking implant result. But if you think about a lot of the implants that you may see, I think most of the time you might go, yeah, I can tell that's an implant. You know, the papillas are deficient, gingival margins deficient. So the reality is, I want us to be able to look at our patients and go, all right, this one, I think, yes, we're going to have to take this tooth out. But I think that there's a lot of teeth that are being removed now that maybe don't need to be. So why do we take teeth out, right? If you look in the literature, there are a variety of reasons that necessitate extraction of the tooth. Endodontics. Endodontics is at the low end. And the reason for that is endodontics is typically a closed system. So the canals can be cleaned and everything can be sealed. It's not often that we need to take teeth out because they don't respond well to endo. So endodontic, less than 10% of the teeth need to be taken out because the endo doesn't work. The large majority of teeth that are extracted are typically extracted due to trauma. A trauma can manifest in different ways. You might have roots that are horizontally fractured and you take those teeth out. Maybe you have teeth that have kind of a coronal apical fracture. So a little bit above tissue, obliquely fracturing down below tissue. And then oftentimes when you have trauma, maybe you get partial subluxation, or maybe the tooth is completely avulsed, and then they become ankylosed. And then we say we need to take them out. Orthodontically, do we take teeth out? Yeah, we do, but we do it because orthodontists need to get teeth over the ridge. And so, yes, 4-bys end up having to still be taken out because there's not enough development of the mandible and the maxilla to accommodate them. But today we would be able to do things with expansion and in other surgical treatments to be able maybe to get room. But if you catch them too late, yeah, you still have to take teeth out sometimes due to orthodontic reasons. Disease, perio disease, right? You get localized bone loss, you get some vertical defects like this. So you end up with short roots. So the question is, even if you get the disease under control, do you take the tooth out because of the defect? Because really what you're looking at is a short root. So we take teeth out often because the roots are short and there's a lot of mobility in the teeth. And then the last reason we oftentimes take teeth out is they're unrestorable, or the patient maybe is unwilling to do what might be required to be able to get more tooth structure to hold on to make it predictable. So what I'd like to do is let's kind of go through trauma, disease, unrestorable teeth, and look at some of the patients that I'm saying are in your practice that typically would necessitate removal of teeth, and talk about when should we really remove them and how predictable would it be if we were to keep some of these problems. So whether you realize it or not, I bet you have a rationale in your head that when you look at a tooth, you kind of go through this checklist and go, okay, if the checklist works, then I'm going to keep the tooth. So if you don't, I'm going to give you my checklist of when I would think about removing teeth. So I remove teeth when I can't control pain or infection, right? So if I can't treat it, I can't make it healthy, I can't make it not painful, those teeth come out. Mobility is an interesting one because I don't take teeth out that are mobile. I try to correct the mobility, splint it to something that isn't mobile. If I can't control the mobility, then I would consider taking the tooth out, right? So there's a difference between mobile teeth and mobility that I cannot control. I take teeth out because they're unrestorable, meaning I don't have enough tooth structure in which to hold on to. I take teeth out because the disease that they have risks creating the same problem on adjacent teeth. And then I take teeth out as part of a comprehensive plan. You know, if you had a tooth that was very structurally weak, or maybe there wasn't a lot of root and bone, and you're doing a big reconstruction, I'll almost guarantee you that that tooth's probably going to fail first. So to increase the predictability of everything that we do, we kind of take the weakest link out of the situation. All right, so that would be my list. And as we go through looking at some of these problems, let's keep this list in mind and apply it to these patients. So let's start with this patient here. And this patient that actually Frank Spear treated, I treated her as well, but many, many years later. So there's the defect you see. It's between the lateral and central in the aesthetic zone. And I can actually predict if I had a magic wand where I want to put the tissue, right? Because I can look at the tissue and the papilla heights of the adjacent teeth and go, okay, those papilla look good. When I start treatment planning implants, what I'm looking for is I'm looking to see where the bone and soft tissue are before treatment. And then I'm starting to apply different treatment options to see what can I do to benefit the aesthetics. So we always treatment plan, where do you want things to be? And then how predictable would it be to achieve that? What we know from the literature is if the papilla is in the correct position, like the papilla between the centrals, that bone is typically 4.5 to 5 millimeters away from that papilla. The challenge that we have in this patient is the bone that is between the lateral and central is 9 to 10 millimeters away from where we want the papilla. And so I still use these numbers that were published in '98 by Garber and Salama, looks at different restorative environments, and it looks at their soft tissue limitations using basically average numbers. And so what we can do is we can go, okay, I know that the bone on the adjacent tooth determines the height of the papilla on an implant. So I could predict if we take that lateral out, what would it look like? We know that when we start taking adjacent teeth out and we lose that supracrestal fiber attachment, we lose the ability to hold tissue at a more coronal position. So these are the numbers that they published, but they're just graphically represented, showing you clinical scenarios. But I actually go through and apply these numbers to a patient. Here's what I mean. You look at that lateral and go, boy, that thing looks terrible. Let's take it out and do an implant. Okay. If you take it out and do an implant, the bone on the distal of that central will determine the height of the papilla. And using that chart, it's 4.5 to 5 millimeters away. So you could say, all right, if we take that lateral out and make it into an implant, we've just exchanged one ugly lateral natural tooth for now one ugly implant. If you go, all right, well, let's take them both out because the bone loss on the distal of the central is as bad, your surgeon's probably going to want to graft it. Well, let's say they graft it and they get 3 millimeters of height. So now, what if you placed 2 implants? With 2 implants, that article would say you can hold up 3.5 millimeters of tissue, but that means that the implants have to be at least 3 millimeters apart, which is nearly impossible when one of those is a lateral. So the reality is you'd probably be able to hold up less than 3.5 millimeters. And you could see then if that was the case, you would still be deficient with the papilla. If you were thinking about taking both teeth out, to me, I would say implant in the central, cantilever the lateral, because the numbers from that previous chart was 5.5 millimeters of soft tissue above the bone. The reality here, though, is that the bone is the issue. And so the best person to vertically move that bone isn't a surgeon, it's actually the orthodontist. Because if the orthodontist could erupt those 2 teeth, you could bring gingival margins coronal, which you need compared to the other side, but you need to erupt 2 teeth to improve the interproximal bone, right? 1 tooth erupting moves facial bone and tissue on that tooth. You want to improve the papilla, you need to erupt 2. So that's exactly what Frank's going to have done. He's going to send it to Vince Kokich, and they're going to erupt the lateral and the central. And when they do, they're going to bring that bone coronal, which means the gingival margin and the papilla are also going to come coronal. You know, when you see this situation here, there's been a lot of disease around those 2 centrals. And you can predict, looking at the laterals and canines, where you would ideally want the papillas to be. If you just take these teeth out, man, everything's going to just really get ugly quickly. But doing orthodontic eruption, if you look at that lower right-hand photo, that's near the end of the eruption. This is the case of Rebecca Backhaus. Now imagine where those teeth would be and look at the gingival margin and papilla position. It's almost perfect. So orthodontically, you can move things vertical so that when you take them out, you end up with a much more predictable result. Now, all sorts of literature out there supporting using orthodontics to treat non-restorable teeth, to also improve potential implant sites. So that's what they're going to do here. Excuse me. They're going to erupt the lateral and central. And as they do, the bone and papilla start to come coronal. So now if you notice, the papilla is significantly more coronal, but it's very flat. It's very blunted. It doesn't look like a nice peaked papilla. So the reason that that papilla is so blunted is the volume of space that that papilla is kind of residing in is really big. So what Vince is going to do is he's going to strip that lateral. He's going to bodily move it over. And when he moves it over, that volume is going to get less. And when it gets less volume, that papilla is going to come down into a nice little peak, right? And it comes more coronal. Now you look at it, and even though it's significantly better from where they started, it's still too apical. So could you continue the eruption? Absolutely. And you could make it into the correct position. But I want to draw your attention to the fact that the gingival margin of that central is actually correct, which means if you were to continue the eruption, now you end up having the gingival margin too far coronal, which would necessitate facial aesthetic crown lengthening, which would expose the root, and then you got to restore the tooth. So could you make it perfect? Yes, but it's going to require additional time and additional treatment options and cost. What do you want to do with that lateral? Do you want to take it out? Because it looks a little suspect at the moment. But what they're going to do is they're actually going to keep it. I mean, you could continue to erupt that lateral until you extract it, but they're going to keep it. And they're going to have Frank provisionalize it. And here is the temp after a year. Notice that there's still a little bit of a black triangle present between the lateral and central. But what Frank will do then is he's going to use a little pink ceramic papillae to be able to get the papilla correct. And you look at where they started and where they ended, and I go, that's actually a beautiful result. But remember, you saw that lateral. And I'm going to guess that many people would say that lateral is coming out. There's nothing left. There's barely any root and bone. So the question is, given how small that root was, how long did this last? So here it is initially, then they did the eruption and then they restored it. And here she is, and it's 6 years, it's still there. Now, at 6 years, I'm in the practice and I see her and she says, you're going to take the wire out. And I said, I don't think so. I said, I think Dr. Spear wants that wire in there in case the tooth is a little mobile because the root's so small. And she goes, oh, no, I'm not asking you. I'm telling you, I don't want the wire there because I can't floss. So I take the wire out. In 18 years, it's still there, right? Remarkable. In fact, she comes back to the office at 18 years. She's not a patient that I typically see every year. She has her own dentist. She comes back at 18 years and she says, it's now the best papilla that I have, right? It's too big. It's too far coronal. It's too full facially. She goes, it doesn't match anymore. Can you fix it? Yeah, absolutely. I can fix it. I can redo that crown, redo the pink. And in the process, I said, I would probably veneer the centrals because they look worn and short. So in year 19, I restore the centrals. I make a new restoration on the lateral with a new pink papillae using today's materials. And so that material, it's actually a ceramic papilla deep underneath the tissue, but it didn't match the coloration very well. So the day I tried it in, I cut the facial half of the papilla back and I layered it with composite, pink composite. So I think all restorative dentists need pink composite in their office. The one that I feel is the best from a color standpoint is actually the one from Annex Dent, A-N-A-X. It's called Annex Gum. Christian Coachman helped develop it. The colors are beautiful. They match most scenarios, and I just have the basic kit. So it's a nice one to get into your office. All right. So how predictable are teeth with short roots? Because that patient, even though there was a history of a problem, once you erupted the tooth, you end up with a short root. So why not just take them out? Why not just take them out and place implants? If you go back to the list, it's not mobility. It's uncontrolled mobility. have you ever done an exam on a patient and then you make the x-rays after you do the exam and the patient's already gone, and you look at the films and you go, oh my God, like I would have never known that those laterals have no roots because the mobility wasn't an issue. But even if it was an issue, I would say, what if I splinted it to the canine? If I splint it to the canine and it's still mobile, now it's coming out. But those short roots, you have to ask yourself, is it a real problem or is it a perceived problem, right? This idea of confirmation bias. You look at the radiograph, you go, that's not normal. That's a problem. We should take them out. But it's a perceived problem. It doesn't fit your ideal of what a norm should look like. The problem really is, can you control the mobility if there is any? And in a lot of these patients, there isn't even any mobility that you need to control. So here it is in 2001, and in 2020, it's still there. Started to get a little mobile, so she couldn't really feel like she could bite into anything. All right, bond a wire to the canine. If it's now still mobile, I would consider it taking it out. The other one still looks pretty much the same, doesn't have any mobility to speak of, so there it is, 19 years later. Now I want you to think for a second. When will these laterals be lost? Well, if she had any sort of trauma to her dentition, probably not going to survive. But the reality is this: the way those laterals are probably going to be lost is she's going to move and she's going to find a new dentist, and the new dentist is going to see those small roots and go, that's a problem. They should have bigger roots. We should take those teeth out. Okay. Now, let's say that something happened and you did have to take them out eventually. They've already been in there 19 years. Imagine the benefits from a treatment standpoint. 19 years, we have gotten so much better with implants, sizes, techniques, materials. It's a way better implant case today because of how we treat implants compared to, let's say, 19 years ago. All right, let's switch to another problem: teeth with horizontally fractured roots. This is a patient who comes in about 2 weeks after trauma, but there's a history. So the history is 4 years ago, he was playing baseball, caught a hot grounder, hit him in the mouth, horizontally fractured the root. He had endo on the coronal segment, and basically he was fine ever since. Now, 2 weeks ago, playing baseball again, which first word of wise to him would be, maybe baseball isn't your sport. But he took another hot grounder, fractured again, displaced it now, didn't fracture the root again, but actually displaced the coronal half into a palatal position. So it had to be ground away so we could bite his teeth together. So this is about 2 weeks ago. There's still some percussion sensitivity. Probing depths are relatively normal, but there's some residual mobility because it's still under a little bit of traumatic occlusion. So you go through, okay, what's our options? Well, you say, I'm going to take the tooth out and I'm going to either do a conventional bridge, a bonded bridge, or maybe an implant. But what about the option of keeping the tooth and repositioning it back into the arch form and restoring it? Now, if you look at the patient's age, he's only 16. So we're not placing implants in our growing population. For males, we're waiting until they're early to mid 20s, 22, 23, 24. Females would be 18, 19, 20. So that takes already a couple of options off the table. Conventional bridge, too aggressive, take it off the table. Implants off the table. So now you go, all right, could be a good bonded bridge case because there seems to be minimal wear, minimal overbite. So maybe it's a good bonded bridge case. The question would be, if you were going to think about keeping it and restoring it, how predictable would it be to keep a tooth that has a horizontal root fracture? Right? So what does it bring into our problem list? Can I restore it? Is it predictable? And because it's got a small root, what's the mobility like? Now, there's pretty good literature out there on survivability of teeth with horizontally fractured roots. The best ones probably did this work from Jens Andreasen. 534 incisors with horizontal root fractures on patients aged 7 to 17. So our patient fits right into the population of this paper. What they did is they classified the root fractures into its location, right? Cervical, mid-cervical, middle, or apical part of the root. And then they followed them out over 10 years. And what's amazing is 80% showed survival at 10 years, meaning 80% of the teeth with horizontally fractured roots were still in the mouth 10 years later. The ones that had the highest risk of being lost, so 70% of those 20% were lost because the fracture is up in the cervical third. Well, that makes sense, right? Because the more close the fracture is to the apical, well, to the osseous crest, the smaller the root for that crown. So if you were to take that fracture location out and redo the stats, doing cervical, middle, or up to the apical, 88% survival rate at 10 years. So what's the take home there? Just because it has a horizontally fractured root does not mean you should take the tooth out. It's not supported by the literature. And I showed you how challenging it is to replace teeth with implants and make it look like it's not an implant. So this tooth was going to be kept and maintained, and we're going to just orthodontically pop it back out into the arch form. You can't really do any intrusion of it to level tissue because you can't control the apical part that's fractured. If you have a tooth that's horizontally fractured and it needs endo on the coronal half, you do endo on the coronal half. If there's a problem on the apical, you could do an apicoectomy on the apical piece, so treat it surgically. Here it is with some interim composite bonding to get the incisal edges level. How well has it lasted? Here's age 16. Here he is at 21. So at 21, you start to be thinking, should we take it out? Should we start considering our implants? Here it is at age 30, and it's still there. Now, there's been an incisal edge discrepancy. The gingival margin discrepancy actually is improved, but the incisal edge discrepancy is because he was still growing when the treatment was performed, right? So that tooth isn't going to erupt because it's now broken, but everything else continues to erupt as his face grows. But now you look at this and go, all right, that's 14 years later. You could easily redo the veneer on that horizontally fractured root, and you can get those teeth to match again, and you're good to go. So the ones that end up with the most highest risk of being lost is when that fracture is in the apical or the cervical third, like you see here. So even though you could say that's probably not a good long-term tooth, you don't know that. And so our rule when we start to manage patients who have fractures is don't make any rash decisions unless you have to. Don't make any rash decisions at the time of the trauma, right? Everybody's freaked out. This patient's 16 years old. She's freaked out. The parents are freaked out. Just bond the piece back in and say, all right, let's all calm down. We'll let the pain go away, the swelling go away. We'll bring you back and we'll make a decision. That fracture location, I would tell the patient, doesn't look great if you look at the literature, but you never know. Here it is 15 years later, and it's still there, right? And again, imagine in 15 years how we would treat this differently than if we were to manage it and take it out at the time and have to do definitive therapy 15 years ago. It still looks like a fantastic tooth, right? So don't bias your treatment because it doesn't fit for what you think it should look like. There has to be a reason to take the tooth out. The last piece with trauma is then teeth that are ankylosed. Ankylosis is essentially replacement resorption, and it occurs when you damage the PDL, right? When you damage the PDL because the tooth falls out and it's been exposed to the air or it's been crushed in a traumatic blow, that PDL dies. And the body's response to that is it sends in cells, and now you start to have bone cells that basically engulf the root. So the root and the bone become fused, and the bone is basically replacing the root. So essentially the patient's doing their own bone graft, right? We look at these radiographically, we see the absence of a PDL, we tap on them and they percuss and sound differently. That's kind of our diagnostic criteria. The question is, do all teeth that are ankylosed need to be removed? And my answer is no, not necessarily. My two questions that I would ask would be, what's the growth status of the patient? And how fast is that resorption occurring? What if you started thinking about keeping teeth that were ankylosed? Well, if you keep a tooth in a growing patient, everything erupts as the face grows. So you end up having the gingival margin that gets stuck in time, and it's too apical. You get this big vertical bony defect. Patients don't feel any different. They only start to experience symptoms when the resorption gets up into the attachment. And the symptoms that they experience are soft tissue symptoms, right? Or what they experience is the crown just basically fractures off, right? So one of those two things typically tends to happen. So the two questions I have are, what's the growth status of the patient? If they're done growing, the risks of keeping the tooth are really low. You could think of an implant as basically being an ankylosed tooth. But if there's a lot of growth potential left, then the risk of keeping it's high, because the longer you keep it and the more growth and eruption occur, the bigger the defect becomes. So it becomes even more challenging to fix when you decide to fix it. Second question is, how fast is the resorption occurring? Sometimes you end up with an ankylosed tooth, but the rate of resorption is really slow, meaning that the root still looks relatively normal 5 years later, 10 years later, right? So you and I cannot predict how fast the resorption would occur. It's unique to every patient. So an adult with slow progressing resorption, low risk for keeping the tooth as long as I can manage the aesthetics. But a young patient with a lot of growth potential, the longer I keep it, the more challenging that case becomes. All right. So now let's go through some examples of ankylosed teeth and apply those concepts. Ankylosed number 9, the patient comes in to see me because she doesn't like her smile. She doesn't like the darkness of her left central lateral, and she doesn't like the asymmetry of the gingival margins of those two centrals. All right. So here's our two questions. How fast is the resorption occurring? Is the patient done growing? Right. So for this patient, she reports that she had trauma when she was 15 years old. How old is she now? She's 62. All right. So what do we know? A, she's not growing, and B, we have a long period of time to look at how fast that resorption is occurring. If you look at the root of that central, it looks pretty similar to the root of the central that isn't ankylosed. So now you go, that's pretty slow resorption. So you could say, well, let's take it out. But the reality is, I'm not taking it out because I think that tooth is going to flunk out because it's been in the mouth quite a while. I would consider taking it out if I can't make it look correct, right? That's the issue. So I would take it out based on the aesthetics, but it's already a survivor. So the question is, can I improve the tissue symmetry? Well, I know I can't move the tissue on the ankylosed tooth coronal, but what if I move the tissue on the adjacent central apical? If I were to do that, would the proportion of those two centrals look okay? I go, yeah, that would look decent to me. The question then is, if you're going to prep the tooth, looking out that it's more facial in its position, if you have to prep that to get it back into alignment with the other central, by the time you get done doing that, you don't have any tooth to hold on to, because look at the size of the canal space. That is all composite. But in this, I don't think I need to bring it back all the way to the position of the other central, because I think that other central could be moved facial. So my plan is I'm going to actually keep these teeth, and I'm going to restore the centrals and the left lateral so I can change the color of the right, or excuse me, of the left lateral and central. And then I can move the tissue up on the right central and restore those three. So here she is, still with the ankylosed tooth, but it has good longevity. I still have nice proportion to the teeth. And given that her lip doesn't go up, even if the proportion was a little bit long, I think it still looks quite nice. All right. So not all teeth that are ankylosed need to be removed. Let's look at this patient. A little different now because now we have a young child. So if you look, the tooth that's ankylosed is already significantly apical, isn't it? All right. So is the patient done growing? How fast is the resorption occurring? The trauma occurred at age 10, and now she's 14. Okay, so that means we have 4 years to look at that root and see what does that ankylosed tooth look like in comparison to the natural central. If it was really quick, then I would say probably going to take it out. The other question would be, so if you look at it, the root itself, to me, looks almost like a mirror image of the other central. So then you go, all right, I just showed you a 62-year-old patient where trauma occurred at 15, and the root basically hadn't changed much in that length of time. So you could say, even though I only have 4 years of evaluation, it could be that this one is a winner that occurs and stays for a long period of time. The question is, can you keep this one? Well, how do we keep the other one? I can't move the tissue coronal, but I moved the tissue apical on the other one. Given how far this tooth has its tissue apical, I don't think you're going to want to keep it in its position because you're not going to want to make the other central with its gingival margin that far apical. But what if we kept the tooth, but we moved the tooth and the surrounding bone into a better position? Because if you look at that right now, and I sent this to my surgeon, I sent this to Jim, he's going to say, that's a tough one, Greg, because look at how far apical the gingival margin and bone are. But now we go, well, that root looks pretty good still. What if we actually did a little segmental osteotomy and moved the tooth and the surrounding bone on that tooth into a more coronal position? I wonder what that would look like. So there's lots of literature to support it, which is exactly what we're going to do here. What Jim's going to do is he's going to do a little segmental osteotomy, but the ideal time to do this would be when the patient stopped growing. Well, try telling that to parents of a teenage girl and say, hey, all through high school and prom and homecoming, you're going to have a tooth that basically is sitting so far up underneath your lip, no one's going to see it. The benefit of waiting until they stop growing would be now you put it into the position, it's like an implant, right? So in the meantime, we've been waiting as long as possible and we've been distalizing this segment. So you can see the widths of the laterals are different. This is going to give Jim more room to be able to cut without damaging that lateral. So he's going to use a mucosal flap, a piezo, and he's cutting through all the way to the palatal bone and all the way to the crest of bone, but he's not removing palatal tissue and he's not removing gingival tissue because he wants to keep that for the blood supply. But if you took that tooth in your hands, you could wiggle the tooth and the bone that's around it, so you know that it's free. It's now no longer confined with the bone. We wait latency about a week, and then orthodontically, we start to move that tooth into position. And if you're going to position it, I would overestimate it. I would actually move it more coronal in anticipation for her continued growth, right? Here it is at 9 months, and here it is at 3 years, okay? Now, there's a likelihood that this progression starts to rapidly go down the road. We don't know, But now imagine if this started to have a problem and you needed to take it out. This is a way more predictable implant now than the initial presentation where the tooth was apical. All right, let's talk about fractured teeth, coronal fractures. These ones you look at and you go, well, these ones obviously you're going to take out because there's nothing to hold on to. So I'm going to give you my thought process when I see teeth that have traumatic fractures, because it might be that we end up taking them out, but there's a chance if it was me, because this patient's 18 years old, if it was me, I'd try to keep the teeth because I can always take them out and do implants down the road. So the question here would be, I need to get more tooth structure to hold on to. Is it going to be restorable? Right? So from you and me, if you're a restorative dentist, my perspective is the most important factor for longevity, if I restore these, is how much tooth structure I have. That's the key, right? If you think about it, I was always told when I was in dental school that, we take teeth out or endodontically treated teeth, let me put it this way. Endodontically treated teeth fail more readily because they get brittle, right? So this is a study that's basically looking at teeth. They're taking natural teeth, extracted teeth. They are pushing on it, and so it flexes, right? A certain amount it flexes. And then they're going to do endo. They're going to access, instrument, obturate, and each time they're going to push on it again to see, does the endo make the tooth weaker? And what they found was basically they lost 5% stiffness in the tooth, and most of that was due to the access. So you could imagine bigger access, cavity preparation, probably more weakness you give to the tooth. But then they took premolars and they actually did the same thing, and they did an occlusal prep and pressed on it again. And then they did DO and MO. And what you'll see now is it's not that the endodontics weakens the tooth, it's everything that happens to the tooth before it requires endo. That's why you end up having to take the teeth out. So I need tooth structure to hold on to. How much tooth structure do I need to hold on to? We typically talk about ferrule, right? Ferrule is the amount of sound tooth structure below your foundation and from your cable surface margin. So if you look, both of these teeth have post cores, but this one on the left, there's no ferrule at all. You go from the margin and shoulder right into the post. Poor prognosis. The one on the other side, tons of tooth structure. Prognosis significantly higher, right? Tooth structure is what we need. How much ferrule? It was from this paper here by Libman. Warren Libman was a faculty member of mine when I was in my graduate program, okay? What he did as part of his master's thesis is he took teeth and he varied the amount of ferrule. So 0.5 millimeter, 1, 1.5, 2. He did post cores and he did crowns. And then what he's going to do is he's going to fatigue these samples. Okay, this is why these fatigue studies are much better than an impact study or an instron study. Fatigue doesn't take a certain amount of force and push on it until it breaks. Fatigue studies take small force and they just tap on it, right? That's how teeth fail in the mouth, right? They continually get used, and then all of a sudden that micro movement causes it to fail. So how do you know it's failed? He's going to put a strain gauge on the palatal margin, and then he's going to tap on it with about 4 kilograms of force. And at some point in time, that strain gauge is going to start to get activity, meaning that margin is going to open up, right? So he's counting his taps, and then right here, every time he taps on it now, that margin microscopically opens up. You and I couldn't see it. You couldn't look at it underneath the scope and make it happen, but it's failed. The strain gauge picks up micro movements. So he would tap, 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 tap until he saw that preliminary failure. What did he find? Once he hit 1.5 millimeters of ferrule, the number of cycles before it actually had that failure went up to 70,000, right? Before that, it was 113 if there was a 0.5 millimeter, and 1,000 if it was, or 113 if it was a half, 1,000 if it was 1. Okay, so the reason that we have 1.5 millimeters of ferrule is because of this paper from Libman. Right, the fatigue study is the crucial aspect there. Where do I need the ferrule? If I say 1.5 millimeters, where do I need it? The problem with Warren's paper was he prepped his teeth like you see on the screen. Circumferentially, he had 1.5 millimeters all the way around. But that's not the way you and I prep teeth. I can't barrel through the interproximal, right? It scallops as it goes over the bone and over the attachment, right? It scallops with the CEJ. So this paper, even though it was not published, is going to do the similar study, but half their samples, they're going to prep like Libman, so 1.5 millimeters all the way around. And then half their samples are going to scallop like a natural tooth would be prepped, where you have ferrule on the facial and palatal, but no ferrule, 0 ferrule interproximal, and then they're going to fatigue it again. So now you're going to see, well, where do we need the ferrule? Do we need it everywhere, or do we just need it on the palatal or facial? And what they found was that you actually need ferrule on the part of the tooth that is resisting tensile load, right? So that would be, you need 1.5 millimeters of ferrule on the palatal of an upper anterior, and on the facial of a lower anterior. Think about how the teeth are loaded, right? So what happens is when you load the tooth in occlusion, way out on the facial margin, you get maximum compression, and way out on the palatal margin, you get maximum tension. What happens as you go into the middle of the tooth, the stresses basically become 0 as you transition from tensile to compression. So do we need ferrule interproximal? No. You need ferrule on the part of the tooth that's resisting the tensile load. That's palatal of uppers, facial of lowers. The problem when you start to look at traumatic fractures, it's the palatal of an upper anterior that has the deepest portion of the fracture. So you have to ask yourself, if that fracture is coming out to a more horizontal exit, can you expose 4 millimeters of tooth structure apical to the fracture? Why 4? I just said you need 1.5 millimeters of ferrule. Yeah, we need 1.5 millimeters of ferrule, but the body needs room for the sulcus and room for the attachment. So bare bones minimum, that's going to be around 2.5. You and I need 1.5 millimeters. So if the tooth comes out more horizontal on the fracture, this is what I need to create. If it's a more vertical shearing fracture, then I could flap it and I could smooth the root, and I just have the attachment onto the fractured vertical root. If it's horizontal, as this one is, I've got to expose tooth structure. So you would then look at, if I need to expose 4 millimeters apical to the fracture, what am I going to be left with? And we would go back into the principle of thirds. Divide the root at that location into thirds. And you would want to see a third tooth on each side and a third canal, or even better yet, more tooth structure in a smaller canal space, because that's going to be your new cable surface. That's where you're going to be your crown prep is. Then the question would be, if you expose that fracture, how much root do you have in bone? Well, I just showed you a bunch of short roots that seem to work pretty well. The reality is, I don't want to do crown lengthening on somebody, or ortho and crown lengthening, and make those smaller roots. My limiting factor is I don't want to make a root shorter than 9 millimeters in bone, right? There's literature out of Europe, ortho literature, to show that if you have a root that's 9 millimeters long or greater, you have 15 years survivability, right? 15 years, that's all the time that the study went. You probably have longer, obviously. So when I'm all done, could I expose the fracture, get enough room for me to have ferrule and have predictability? Yeah, I think it could. But I wouldn't do it just surgically, and I wouldn't do it just orthodontically, because the challenge here is, if you did it just orthodontically, you're not going to have enough root remaining, right? If you did it surgically, you'd have to move bone and tissue, and all of a sudden this becomes very ugly. But if you combine those options, orthodontic eruption, just to move the interproximal fracture into a coronal position where I could keep the bone where it is now. Because if the bone is where it is now, the papilla is correct, right? So I'm only going to recommend 3 millimeters of ortho eruption. That moves the interproximal fracture into a position that is just above, sulcus depth, right? So that I can actually have my margin on sound 2 structure and the bone is in the same spot. But 3 millimeters of eruption doesn't expose the entire fracture. So then we can actually do conventional crown lengthening to expose the remaining fracture, right? So I need to give the orthodontist something to hold on to. So we move tissue, I bond some post cores in, I bond a couple of temps on, and then we erupt it. And for my orthodontist, I said 3 millimeters is all I need. Once we hold it there, now we can come back and do surgery to move bone and tissue on the facial, to move bone on the interproximal, and then to expose the remaining fracture on the palatal, right? So move bone so I can get the gingival margin back to correct, but that interproximal bone height is going to be able to be in the same position essentially that it was to get that papilla to be in the same position that it was, right? So here it is now post-surgery, and look at where my initial preparation is. It's at the position I would want it to be in the sulcus. So I have the bone and the papilla in the correct spots. Here's the final preps, and then the final case, again, greater than 9 millimeters of root still in bone, right? So here it is when I finished him, and then I was sent these photos. Here he is at 14 years, and the teeth still there. Right? So again, I'm hard pressed at times to think about taking teeth out. How much tooth structure do I need? Palatally, we said we need ferrule, but what's my prep height? How much prep length do we need? This tooth fractured off the coronal piece. So if you look at a couple of papers, a short clinical crown is defined as anything with less than 2 millimeters of sound tooth structure after you do your preparation, right? So right now it's looking that 2 millimeters of tooth structure might be the number. This paper here from Wiscott says that a bond restoration with the prep height of 2 millimeters exceeded the fatigue resistance of a 5 millimeter prep with a cemented restoration. So 2 millimeters is my marker to get resistance and retention form met. Where do we measure the 2 millimeters? We measure it interproximally, right? Which means we probably have more than 2 millimeters if you measured it on this patient, measured it from the palatal. So that tooth, we can take the rest of the material off. I don't need to build it up. Do a bonded restoration. It had 2 millimeters of interproximal prep height. This is just a bonded Emax single unit restoration on that central. Right, so let's end with a little bit of literature here on materials. So post-core and cement. I'm going to show you 3 papers to wind us up here. This is a paper from my good friend Yoshihiro Goto. He was in grad school with me. He was a few years behind me. And what he's doing is he's going to test 3 different types of post cores, right? Gold post core, a parapost with a composite buildup, and then a fiber post and a composite buildup. So essentially, he's answering the question, and you've probably seen this before, where they say, well, your post should flex because your tooth flexes, because stiff posts break teeth, right? So if you look at the materials and you look at the modulus of elasticity of dentin and enamel, yeah, the fiber post flexes like dentin, and the other 2 posts are quite stiff, much, much more stiff than the enamel. Okay, so he's going to fatigue it, and he's fatiguing it using 8 kilograms of force instead of 4. So he's doubling the force, which enables him to cycle through his samples quicker. What did he find? What he found was the one that had the fiber post had significantly more cycles before it fatigued. So you go, okay, maybe the fiber post is what we need to be doing because stiff posts break teeth. But there's a problem with his literature. There's a problem with his design. What caused the higher number of cycles before it fatigued? Is it the flexibility of the post, or is it the fact that that entire system has to be bonded? Your core and your post are bonded, whereas the other two, the posts are actually conventionally cemented. So the next study is going to supplement what Yoshi did. So it's going to take this exact same samples, but now bond everything together. Bond the post core that's gold, and now do the exact same cycle again, 8 kilograms of force. Now you're really looking at the post. Before, you couldn't tell, was that post that did it, or was it the fact that it was bonded? Now the numbers are dramatically different compared to where they were, right? So the flexible post is much weaker. So once you start to lose tooth structure and it flexes, it's going to fail, right? Because what doesn't flex? Your bonding, your resin cement does not flex. So now if the whole thing were to flex, it's going to fail readily. So the stiffer posts seem to respond better to fatigue, right? Before failure occurs. And even though there's a big difference between, gold is stiff, stainless steel is significantly more stiff, right? 163,000 versus 244. So then you go, wow, if that's the number of cycles, because remember, the first study used conventional luting and had 4 kilograms and it was 70,000 cycles. This is 240,000 cycles. Maybe, just maybe, if we bonded the crown on top, maybe we don't even need 1.5 millimeters. So this is the last paper that was done. This one was published. They're going to use the weakest of the systems, but they're going to bond everything, the post and the core, as well as the crown. And they're going to now go no ferrule, 0.5 millimeter ferrule and 1 millimeter, bond the crown and test everything again. So place your bets. Actually, the one that had no ferrule still was very, very poor, right? But look what happens in the weakest system when you bond the crown as well. 0.5 millimeter of ferrule jumped up to 155,000. 1 millimeter was at 262, right? Now imagine if you were to put a stiffer post in, these numbers are going to spike even higher. So the reality is what? The reality is you could use any post material you want, as long as you have enough tooth structure, and all you're doing is you need a post to retain your core to get more than 2 millimeters of prep height. But for me, when I start lacking tooth structure, I would tend to now want to go to a stiffer post, right? You're exchanging two things. The fiber posts will break. The stiffer posts will fracture the root. But the reality is they're still both catastrophic failures to me. But I would rather have it be in the mouth longer before the failure would occur. So here's a situation, pull off the old rehab. It's got nothing good underneath it. We redo the endos because the endos had some lesions, and I'm going to build them up with a stainless steel and a composite core, right? Because those numbers were the highest. I have enough ferrule on the palatal, and I have enough thickness of that tooth structure. The thickness we need is about 1 millimeter of thickness of the wall, right? So here's the temps, and here's the patient at an 18-year follow-up. Teeth are still present. All right, so in summary, I think that we take teeth out too readily in dentistry. Implants are great, but they end up having their own challenges and their own unique set of problems. So before you think about taking a tooth out, ask yourself, is the problem that you see a real issue? Or is it something that's perceived? You've biased it because it doesn't fit the way you think it should fit. And I believe that if you utilize some of the concepts that we discussed today, you may find that you end up taking fewer teeth out. Keeping natural teeth keeps natural aesthetics. All right. So I know we have a few questions. I'm going to unshare here, and I'm going to click on the questions, and we'll see if we can answer some of them. Because we can go over a little bit, Jerry, can't we?
Yeah, a little bit. I think it's fine. If your schedule and their schedules are
Yeah.
okay. Some of these are good questions.
I got a patient at 1. It's 1 o'clock my time, but you know what? I'm never first one in the room anyway. All right. I was told that age 25 is the cutoff for forced eruption to bring down bone. No, you can do forced eruption at any age. Age is not a factor for any type of orthodontic movements. So nope, doesn't matter the age. Original reason for bone loss between central and lateral. Good question. It was a case that Frank and Vince saw many years ago, and they didn't really know, but that patient had a sister, and the sister had the same defect. So what they hypothesized is it was an anatomical defect on the tooth. Maybe there was like a root, kind of a crevasse on the root, maybe an enamel pearl, but they didn't really know. It wasn't disease. They think it was more anatomic. Pink ceramic, how do you clean underneath it? The pink ceramic is almost like, it's not an overhang, right? Now we're getting into semantics. An overhang is an area where you can't clean. This is an over contoured piece of ceramic. So it's convex, right? So you can actually floss underneath it. It's almost like, think of it as a mini ovate pontic, except it's a papilla. So you can actually floss it. It has to be cleansable. I think if you look, there's a lot of stuff you might see on social media where they do these like really fine overlays of pink composite and ceramic that are facially overlapping the ridge. Nope, that doesn't work. You cannot clean underneath it. But this is a papilla. It's almost like a little ovate pontic. So easy for patients to clean. Water picks also tend to work really well. Crown lengthening. So to expose a fracture, you can crown lengthen it, but when you move bone, tissue moves as well, right? So you can crown lengthen in unaesthetic areas and the teeth get a little longer, and I'm okay with that. In the aesthetic zone, if I need tooth structure, I would erupt it, and then I would crown lengthen it back to be able to expose fracture and to put the bone back in its anatomic position. So the papilla is continually supported aesthetically, right? Would you have more bone loss by waiting on extracting of the laterals? No, not at all. The lateral roots were not small because of bone loss. They're small because of resorption of the roots. Typically that root gets resorbed during eruption of, like, primary canines erupt in, they erupt after laterals. If they erupt in measly, they can wipe out the lateral roots unless somebody catches it. So if the bone loss, if it was bone loss on those laterals, your papillas would be apical, right? The papillas were perfect. The roots of the laterals were the issue. So it's not disease, it's that something resorbed those roots. And typically it's another tooth that erupts when the patient was growing and developing. Is the function of short roots compromised worse, better than implants? Short roots, just because it's short doesn't mean it's mobile. It doesn't mean you can't function on it. You've probably, and again, you've seen this in your practice. I guarantee you go, holy crap, that root is 2 millimeters. I never would have guessed it, because when I did my mobility testing, everything looked normal. And I have tons of patients out there with small roots, but I don't keep a small root if the patient can't function on it. That's a different animal, right? I say, no, you can't eat off those teeth. No, they're just for looks. Then I would say, try to control and improve the mobility. And if you can't, then I'd probably take it out. But a lot of teeth, they're not mobile at all. And the patient can function on it like it was a normal tooth. Bond a wire around the palatal, right? If that helps mobility, keep the tooth, great. Then help the mobility and keep the tooth. So again, I'm slow to take teeth out and put implants in. You got to have a pretty good reason why. And also laterals. Laterals are actually great teeth with, let me rephrase the question or the answer. Laterals can be really predictable teeth with short roots because you can protect them occlusally, right? You don't have to have any protrusive or lateral forces on those teeth. So if you say, what's the best tooth to have a short root? What's the one with the biggest longevity? Or lateral, right? They're just easy to protect. Can you review the slide showing predicted tissue papilla heights? I can give it to Jerry and he can put it in the chat to everybody. Or here, let me just do this real quick. If you're still on, I'm going to share my screen and you can just take a picture of it. That's probably
do a screenshot.
Yeah, that's probably easier. And I'm going to give you.
And while you're bringing that up, as a reminder, this recording is going to be available in 5 days and be emailed to you. So you also will be able to review this material from the video link.
So take a photo of that, screenshot with your phone, whatever it might be. We talk about this in treatment planning workshop. We talk about it in our implant workshop. So there's a few other areas that we hit on this at Spear. So there you go. There's that. We'll stop share. There's just a couple more questions, Jerry.
Yep.
So when you have a fracture, the question is, does it need endo? If it needs endo, if you have symptoms, it needs endo if you have a radiographic lesion. But just because it had trauma, especially if the patient's younger, it's amazing that those really a lot of times don't require endodontics. So there's no pain. If there's pain, yes, then we would consider doing the endo piece of it. But otherwise, not just because it had a fracture doesn't mean you need to do endo on it. If there's symptoms, different, right? Ferrule for posterior teeth, still the same positions. Think of it this way. You need it on facial and lingual, or facial and palatal. You really don't need ferrule interproximal. And here's another reason why. All teeth are mobile buccolingual, right? So now imagine your ferrule interproximal. It's in the same direction as your force. So it's really not providing you any surface because it's in the same basically path of insertion. Now, if you said to me, I have a root canal treated tooth and it's got a bridge on it, game changer now. If I have a bridge, I want more ferrule, I want more tooth structure everywhere because it's going to catch some different loads now, right? Recording is available for viewing, yes. Multi-rooted teeth. The challenge with multi-rooted teeth is this. You can't do a lot of crown lengthening on a multi-rooted tooth because you don't want to expose the furcation, right? So the challenge when you start exposing furcations is you create a very hard to clean area. So crown lengthening in the molar region is a little more limiting for us, right? But it also depends on the anatomy of the teeth. Ferrule still applies for posterior teeth. Palatal ferrule for maxillary posteriors, facial for lower posteriors. Yeah, it's the rules still apply. If you can get more tooth structure, that's the key. Yeah, like the more the tooth structure, the more predictability you have. That's really is the key. So if you're scrimping on it, right? If I'm scrimping on ferrule, then I say, okay, I want it on the facial and palatal, facial lingual. And then I'm also going to start bonding things together. Like if I do a buildup, it's bonded. The crown, it's bonded, because bonding raises the number of cycles before it starts to fail, right? You start listening to people talking about biomimetics and they would say, no, my God, I'd never do a stiff post. You're just basically deciding how you're going to want it to fail. Because if you don't have any tooth structure, even with some of these biomimetic principles, you're still stressing those materials, and that flexible post is probably going to break, right? And you just anticipate that that's the way the failure is going to occur. But talk to an endodontist about removing fiber posts. It's not easy. And when they do, they end up getting a bigger canal space. So then it's just you're creating a different failure, essentially what it is. For me, I'm okay with a stiffer post, because I know the literature says that's going to have way more cycles before it fails, When it fails might be ages down the road, but how might it fail? It might fail with a fracture in the root. I'm okay with that because I think I've gotten a good lifespan out of it, as opposed to continually having to treat it, do dentistry, keep charging the patient time and time again. Like my patients, when they're done with me, they want to be done with me. They don't want to come back in 2 years or 3 years or 5 years and go, okay, now you get to do it again. I get to pay you again. Right. So it's a matter of just choosing how you want to proceed, because both ways can work. You're just accepting a different failure pattern. All right. Good. I know I ran a little bit late.
I think that was worth it. It was great. There's so many comments in the chat about how they're so happy somebody's finally explained this.
Well, I appreciate you guys taking the time out of your busy Wednesday. I know that I am now going back to my other job, which is treating patients. Hey, I tell you what, if you haven't been out to Spirit Education or you haven't looked into what else we have to offer, I'm a little biased because I'm so heavily involved in it, but there is no better place for dental education, in my opinion. The workshops, the virtual seminars, we have such an amazing group of faculty. So hopefully, look into the Spirit online, see what we have to offer, and hopefully get involved at a different level. And maybe, just maybe if you come out to Scottsdale to take a workshop, grab me and say, hey, I saw your webinar on Restore or Replace. So say hello.